So we understand pilot can run in flight in nice weather, but there are some clippings. If we see in cataract surgery, especially in three terms, either posterior capsular rupture, genular dehiscence, or the catastrophe one, the nucleus drop. Here, the pilot's efficiency is proved, and hence it is related with the cataract surgeon, how it goes. So let's enjoy this video. So my ultimate goal will be, go through this course that in a very turbulent scenario, how to prove the pilot is so much efficient. The goal in aviation is safe landing with the passenger. Here is a safe outcome with the cataract patient. So first tricks will be assessment of PCR before surgery. If there is any PCR during the course, diagnose at it the earliest. And third most important part is manage it efficiently, step by step. So you can see there are some photographs. Suppose this is a case of posterior polar cataract. So nowadays, with the advent of technology, if you have the access, even you can diagnose there is some posterior capsular gap or not with the high definition OCT. But it is possible if even if you don't have the high definition OCT with the slit lamp examination also. So there are different reasons where should we suspect that it may land into an PCR, starting from small people to hard cataract, pseudo exfoliation, traumatic cataract, etc., etc. Now, let me share with my first video That's in case of nucleus drop because of the postcapsular tear. So here with a 3-port vitrectomy, pars plana vitrectomy, you can see that almost entire nucleus is on the retinal surface. So principle here is to remove the vitreous cavity as a whole. First is doing the base dissection. Base dissection of the, we understand from our background that the vitreous is attached in 4 places. One is the vitreous base. So we have to remove it carefully. And then introducing the fragment, we can do an emulsification itself within the vitreous cavity very safely. It's in semi-soft cataract. Little tiny pieces here and there. So triamcinolone is given so that it stains. It enhances the visualizations so that the vitrectomy could have been completed entirely from the base and enter vitreous cavity. Side port are mint. Iris here is round. The tunnel is being prepared to introduce an iris flow IUL. Pilocarpine is given with a special forceps. The IUL is being held. First loop is going behind the iris and it is to be tacked. Changing the hands from the opposite side port. Another haptic has been taken behind the iris and it is being tucked. So now it is fixed. And then vitrectomy completed and ultimately suturing the wound. And the surgery is complete. Now, few dilemmas are there. Usually when we put the IUL in case of sulcus, mostly preferred. Nowadays it is also getting popular, this iris fixated IUL. So these numbers are less, but always keep into mind a constant also has to be kept in mind while we are calculating, when we are changing the brain. Even then there is a formula, rough formula. If it is in the myopic side between +5 to 9 and in the same brain, we should not change the IUL power. And if it is very high hypermetropic like +30, 35, we should reduce by -1.5 diopter or less. Now, there are so many signs how we can identify this case as developed in PCTR or not. Most importantly, sudden constriction of the pupil. We understand because the pressure has gone down and iris falls back and it constricts. Loss of flowability, that is because of the presence of the vitreous, and shallowing of the anterior chamber sometimes if the vitreous cavity goes up. So these are the cardinal signs. We know about it. Now let me analyze one very easy cataract, soft cataract. Drexis. There is nothing to share in fragmentation and fragment removal. Irrigation aspiration is going on. Almost 80% is complete. OBDs are being injected and you can found in linear PCR. So how to go about it? Here it is in 3-piece IUL. It's being intended to put in the bag. Always has to keep in mind that the PCTR size should not enlarge. You can see all the maneuvers, that is, there is no fluctuations in the compartment. Entire process is very slow. Rotating the haptics very slowly within the capsular bag. First loop has been taken care of. Somewhere it is stuck. IOL is brought into the center. IA to remove some of the OBDs, but the IOL is tilting. It means some of the vitreous is there. So OBD is being injected. This is being magnified. Vitrectomy machine is getting ready. One haptic came out. With extreme precaution, that haptic to be taken into the bag. And also have to keep in mind that haptic location should be perpendicular to the TR location. Vitrectomy started. First it is in the cut mode. We know we have to cut the neck. Base of collapsing vitreous. With the highest cut rate, here cut rate is 4000. Aspiration is low. There are so many questions about the fluidics. IOP here is 34. Vacuum here is 210. Now cutter is being changed. Now wounds are being closed. Checking IOP. Pilocarpine has been given. Somebody put me this question that if I don't put triamcinolone, so this is known as pilocarpine test. You can see weight, how regularly it is constricting. And now I am completing, some of the OBDs are there. Doing an irrigation aspiration to remove leftover OBDs. And again, it will be rechecked. Intraocular pressure will be rechecked. One cushion is there. It should not be too tight. It should not be too loose. You know the reasons why it should not be very tight, why it should not be very loose. Now, you must be having different machines. In Alcon group, either Laureate or Infinity or Centurion. So there are two modes. One is cut IA when I need to start vitrectomy. The cut rate remains the highest, whichever Laureate gives a cut rate of 1500 cut per minute. Infinity gives maximum 2500 cut per minute, and Centurion gives an 4000 cut per minute. But when in the IA cut, when this base is being cut of the vitreous, we first aspirate the thing and then cut. The cut rate comes very low. So in cut IA, the cut rate is highest, and IA cut rate is lowest, 250, 250 and 400. In case of bottle height, this is 55, 55, 40, 55, 55, 40 in both the phases. Aspirations is also, in case of Centurion, this is little bit less, 15, 16 recommended by the company. But in case of Laureate and Infinity, this is 20 cc, 20 cc aspiration rate. Regarding vacuum, this is 200 to 300, means it is moderate vacuum. So that is about the settings of cut IA and IA cut. Now I'll be sharing another video. That's also an easy cataract, well dilated. Praxis went well. There is nothing to share with you regarding nucleus removal. It's in grade 2 cataract. But to an utter surprise, while the last piece was removing, you can see a small tear. I mentioned you that should be detected at the earliest. So the irrigation aspiration started. You can notice a linear line of PCTR. But one point is very sure, if you maintain these 4 compartments. When I say compartment, that compartment between the back of the cornea and the iris, then iris and the anterior capsule, and then definitely the compartment between the posterior capsule and the anterior capsule. That had to be maintained always. So first in an attempt, it failed. You can see compartmentalizations with the help of the OBD. One of the compartment in the first attempt failed. The capsular bag came collapsed. Now once it is inflated, you can see how easily rest of the cortex can be removed. But yes, with this exercise, the tear has extended little bit, but nothing to be scared of. The patient is under topical anesthesia. Here the scenario is not like this. The previous case, here is a huge tear. So the planning won't be that rational to put this into the bag. It will be rational to put in 3-piece IOL into the sulcus. So you can see the first haptics has been opened, taking its course. is mixed up with some of the OBDs. Trailing haptics has been taken care of. A gentle rotation. In the small people I mentioned, if you are not very sure, even in this stage, you can retract the iris, can make the opening bigger. Now, the advancing haptics, which has came out from the sulcus. Take your time. Rotate the IUL, maintaining the plane. And nicely you can put it in the sulcus. Then if you wish, you can give triamcinolone assisted vitrectomy. Here I didn't give, because what I do, I use the microscope very prominently and I have a good viewing system. So it is possible to see even the vitreous fibers also. So the vitrectomy started. You can see the cut rate is highest. It is in the cut IA phase. I keep always very low aspiration. You can see aspiration here is 10. Pecom is somewhere 250 around. So I am checking all around by aspirating. Is there any vitreous fibers left? It's first 180-degree completed. Next 180-degree I am just going for, looking for any tags. IUL is well secured. I didn't do even the pilocarpine test. So after that, now I am checking with the intraocular pressure, expecting a good result. So pilocarpine has been given. Now doing the IA, removing the leftover OBD, and that surgery is complete. This is one of the fundamental video. Again, I will play. I won't speak. So you can enjoy that is being a video that is called mark. Should be a balance between between the anterior part and the posterior part. In front of the posterior capsule and behind the posterior capsule. So enjoy this video.
As Edward Murphy once said, everything that has to go wrong always does. During cataract surgery, the posterior capsule acts as a barrier between the anterior and posterior compartments. An equalization of pressure between the two compartments is of utmost importance to maintain the integrity of this barrier. Any imbalance in pressure between the two compartments will lead to a breach in the barrier. In the first case, we see a routine cataract surgery being performed. After nucleus emulsification is complete, the surgeon notices a spontaneously occurring PCR, which within the blink of an eye extends to the periphery. There is momentary shock. but the surgeon assesses that the anterior vitreous space is largely undisturbed. The chamber is adequately filled with OVD, and cortical removal is attempted. Which was successful. The chamber is once more filled with OVD, and the intraocular lens is implanted in the back. The haptics are placed such that it stabilizes the PCR. In the second case, we see a posterior polar cataract. Successful nuclear removal. Removal of the cortex begins. And is completed without any roadblocks. Notice that on the surgeon's right hand is the irrigation fluid. After the cortical removal was complete, the surgeon is now ready to implant the intraocular lens. However, he notices a spontaneously occurred PCR. In both cases, we see an imbalance in pressure in between the two compartments, leading to a breach in the capsule. In the first case, we propose a theory that due to inadequately filled anterior chamber with OVD after removal of the nucleus, along with an increase in the positive vitreous pressure, there was a breach in the capsule. Similar to a pressure cooker, where the steam builds up pressure and at one point gives away. In the second case, we propose that the jet of irrigation fluid from the irrigation cannula caused a momentary imbalance in pressure in the anterior compartment and led to a breach in the capsule. Just like this. To conclude, spontaneous posterior capsule rupture can be encountered in the operating room. Rule number one is to not panic. Remember the Murphy's Law. These cases can be managed as routine PCRs. In most cases, we noticed that the anterior vitreous phase was largely undisturbed as the ruptures happened at the end of the surgery. Adequate filling of the bag in all stages of the surgeries with OVD is of utmost importance to maintain the pressure gradient between the two chambers. Intraocular lens can be placed in the bag with the haptic stabilizing the glove.
So it's self-explanatory. What is mean that equilibrium both from the front side and the back side of the capsule, if it is being affected, it can posterior capsular rupture. So if time permits, I'll go for one or two more case. This is an PPC. It's not my video, I have taken from the library. Nice CCC. Sclerocorneal incision. incision for the echo probe 2.8. Now an hydro. So if you notice, by the meantime, because of the people started constricting, there is loss of support and a PCR happens. Our learning in this case is something definitely when we'll be talking about, we had so many discussions about PPC. So it is confirmed. Now let's manage this case in other way. This is not today's topic. I'll be discussing here one case of mine to share with you. This is a routine case, incision. Nothing to be shared that much. This is in morning OT. We remain usually a little bit in hurry. Things are going well. Irrigation aspiration is also went nice. IUL is going to be inserted, but there is a sudden jerk. Now you see the entire half of the bag has come down, and this is in the wound. Now let's see how do we proceed. So initial attempt is to inflate the bag. We understand making compartment. Fixing the eye, inserting the IUL through the wound, very gradual. But as the patient is under topical, we cannot help experiencing some pain. But you can see this again after introduction of the IUL, this bag is trying to come out. Means there is an huge jonular dialysis. Now, these portions of the IUL has really gone to the vitreous cavity, so trying to retrieve it. And behind, about the half the capsular bag has come out. So one haptic is outside the capsular bag. So the first attempt we are trying to retrieve the IUL, maintaining the pressure. But as because we give some OBDs, this disinsertion is going to be increased little bit more. So it's a kind of manual stretching of the capsular bag. So IL gone further behind. 1/3 was outside the bag. Now it is more than half is outside the bag. So one of the haptics, main dangerous haptics, has been retrieved on the top of the iris. Here is the importance of the capsule tension ring. So once the capsule tension ring is being placed, I am just going little bit fast. Now the bag is stabilized by the CTR. You can see it has gone to this place. Now it is confident to take the IOL into the haptics into the capsular bag. Now attempting the other haptics also to put in the capsular bag. Now I will be rechecking, doing anterior vitrectomy. Question, I didn't fix it to this para. The reason is it is traumatic one. And ultimately, next day when I saw the patient had 612 unaided vision. This is a different scenario I am going to share with you. Not all the time. This is also in routine cataract. Nothing to share with you. There is some problem in the IOL loading. It's a new IOL. So eye is inflated by BSS with the irrigation. That's fine. Now IOL is being inserted in the eye in the capsular bag. To an utter surprise, you can see at 6 o'clock what has happened. Now, if it would have gone so forcefully into the capsule, it would have led to PCTR. Now it became a 2 hours job. It didn't turn into an PCTR, but really to a small iridodialysis and lots of bleeding, and it took another 1 hour time. This is again a small video. First one I shared with you with a complete vitrectomy, but sometimes that require the presence of your VR colleague, but all the place your VR colleague may not be available. It is also in routine case. But see, the entire capsular bag has come up. Now it turned to an ICC. So the rescue is same. Here for last 8 to 10 years, we are implanting this iris flow. If the iris is diseased, then we go for scleral fixation. So putting triamcinolone check. And then we'll be doing the vitrectomy, suturing, and complete. It's not a very complicated process. It's easy, and the result is also very rewarding. Next portions, I'll just skip. Don't hesitate for conversion. This is a very hard cataract. Had some problem. So it is being, you can see, no hesitation into making a sclerocorneal tunnel. Patient was under topical anesthesia, but what I did, I gave some 1 cc to 1.5 cc xylocaine just beneath the superior rectus and wait for a minute. It becomes painless. Then all the nuclear big and small fragments are taken out by the visco expression. Doing the vitrectomy, I have shared with you. This is a huge PCR. You can see, but had an intact CCC margin. At the completion, what I did, after completion of this, I put a 3-piece IUL and sutured the wound. And ultimately, where I started with the turbulent weather, it proves how the pilot is efficient, that in safe landing with a safe outcome with the.
So you have to unmute, sir. Your voice is not audible. Please unmute, sir.
Thank you, Chandan, for this.
Yes, sir.
So this patients requires a little bit more visit. Educate the patient at the time of discharge that nothing to be worried about. Your course may take little bit more time. And instruction that dilate the patient in first few weeks to check the retina if there is any tear. Monitor intraocular pressure closely. The reason is this, because of the OBD, sometimes it goes up. Post-op medications is the regular antibiotics and steroid. NSAID to be continued for 1 to 3 months minimum to minimize the chance of CME, because these people are more prone to develop CME. And anti-glaucoma and dilating drops. If there is lots of inflammation, then probably dilating drops will be required. And if the intraocular pressure remains high, you need anti-glaucoma medications. Else, even with PCR, not to panic. If you can identify the case that this I may lead to PCR, if you can identify it first, and if you step by step manage, it gives almost normal result like a normal cataract. With this few words, I